As I go through, please feel free to type things in the chat and I'll pull away and I look at the chat for questions. If you want to, you can unmute and ask questions too. I really don't mind being interrupted. Let's see in the chat. Can we go over the clinical correlates towards the end since you didn't really get to do them yesterday? I think it was like the last 2 or 3 slides. Sure, we can do that. Actually, since I did go over this whole presentation yesterday, we can start there and then we'll double back. So starting with clinical correlations. All right, here we go. All right, so clinical correlations for axilla and collateral circulation. So yesterday I got to talk about the collateral circulation around the scapula when it comes to blood supply and how you're going to need to memorize the different branches that give blood circulation to the scapula. So the thing about it when it comes to collateral circulations is this is important for many different parts of the body. Specifically, if you'll notice here in this picture, you can see that they have an imaginary ligature here of the axillary artery. So that's making the point that if you have a patient that has some sort of compression or some sort of laceration, basically if you cut off blood supply from the axillary artery to the brachial artery, the body is able to get around it because you have this collateral circulation, because you have blood from your subclavian artery that's going to your scapula, but then can go around your scapula and go into your brachial artery here. So even if you have this area blocked, the body has a way of bypassing it because of this collateral circulation to still get blood to the upper limb, blood up to the arm. So that's what this is in particular talking about. We already listed like the different, excuse me, the different arteries for anastomosis around the scapula. So, and this is like the compression of the axillary artery. That's the ligature here. That's what it's talking about. Compression of the third part against the humerus may be necessary when profuse bleeding occurs. Can be compressed as origin by exerting downward pressure in the angle between the clavicle and the inferior attachment of the sternal cladomastoid muscle. Okay. Aneurysm of the axillary artery. So whenever you see an aneurysm, it's always like aneurysm is an enlargement of an artery. So you see how in these pictures, like it's nice and smooth and everything about these main arteries looks to be about the same size. And aneurysm is when you have like a bulging out or a ballooning out of the artery. And you can see aneurysms in almost any artery in the body. Later on, when you get further into anatomy, aneurysms become really important in the head for like circulation for the brain, but you can have an aneurysm anywhere. For the abdomen, a big one is the abdominal aortic aneurysm and how it can like kill people really quickly. So aneurysms are everywhere, but specifically aneurysm for the axillary artery. So it's an enlargement. It can occur at the first part of the artery and compresses the brachial plexus. So you can have here where you have an enlargement of an artery and though blood is still flowing, because you have this enlarged portion of the artery, it will compress the brachial plexus and that compression will then make it so that the nerves can function properly. And so your upper limb will have weakness in different actions. Let's see. Injuries to the axillary vein can be caused by wounds in the axilla. It can be dangerous because of profuse bleeding and risk of air entering the blood. Okay, so your axillary vein, does he show it here? Sort of, but it's not labeled well. So, okay, here's your axillary vein. And remember how we talked about yesterday, how the main veins of the upper limb are your basilic, your cephalic, your median cubital, and then this axillary vein. So this axillary vein has drainage of a lot of blood that's going back towards the heart for oxygenation. And so since it has a lot of blood in it, if it's damaged, you run the risk of bleeding out. I was chatting with somebody yesterday about how there's arterial blood versus venous blood, and how it is in general more dangerous for you to have damage to arterial blood supply, because arterial blood supply is under high pressure. So if an artery gets nicked, the blood will come squirting out and you can basically bleed out faster. For venous blood, it's more of an oozing, because you have that, excuse me, you have that low pressure of the blood that's gone through the blood vessels. So you've gone from arteries to arterioles down to the capillary beds, where you've decreased that pressure along the way. And then the blood has then gone from the capillary beds to the venules to the veins. So your blood is at its lowest pressure right before it gets into the heart. However, having said that, because the axillary vein is a large vein, so even though it's under less pressure, there's still a lot of blood there. So you can still end up bleeding out by damage to that vein, just because of the sheer amount of blood that can be bled out from it. Okay. And then also when it comes to air entering the blood, so this is how air embolism, this is obviously air embolism, not good, but that's one of the ways you can die as well. I think they like depict it in like movies or something like that as something very dramatic. But yes, air embolism can cause you to die. It'll end up that I believe it's the air entering the heart and disrupting the normal pumping, so that can end up like killing you. But yes, an air embolism, like you can die that way, and that ends up being an injury or a like hospital incident that we worry about when you're putting in a central line. So a central line is when you're putting in IV access to a main vein. Specifically, when you guys get into practicing, it'll be the central line by the clavicle for like the subclavian vein. But that's a way that, like, if you're not careful, if you don't know what you're doing, if you're not properly trained, you can cause an air embolus to happen when you're putting in or taking out the central line right above the clavicle for the subclavian. So yeah, air embolisms, you definitely want to watch out for those, because a person can die that way. Role of the axillary vein in subclavian vein puncture. The needle actually enters the terminal part of the axillary vein and then enters the subclavian vein. Okay, so this is just going along with our conversation yesterday when it comes to blood vessels. So all of these blood vessels, they have different names, but everything is just a continuation of something previous. There is no separate subclavian artery from axillary artery from brachial artery. It's all just the continuation of a blood vessel, but we have named them differently because they're in different areas of the body and different branches coming off. And it's better for us to pinpoint exactly where in the body we're talking about the blood vessel if we give it a name. So here, talking about the fact that the axillary vein continues on as the subclavian vein. And actually, let me see if I can find, I have a picture somewhere in one of my review PowerPoints that can show this a little bit better, how it's like a continuation of one into the other. Because it's pretty important to understand that you're naming a vessel based on where it's located. Because they're all just, like, your body is a network of things that are all interconnected. Let's see. Blood. Here we go. That's a little bit better. Okay. So you can see here how you have, like, there's your cephalic vein, there's your basilic vein, here's your median cubital. It's not labeled, but this is it. And then you can see how your cephalic vein is emptying into your axillary vein. Well, then underneath here, this is your subclavian vein. But notice how it's all just a continuation. So your basilic vein is continuing on as your axillary vein, and then your axillary vein is continuing on as your subclavian vein, and then your subclavian vein is going to join together with your IJV, your internal jugular vein, in order to create your brachiocephalic vein. So these are all interconnected. These are all just like, it's all just a web. It's a network of vessels, and we're naming them based on where they are, so we better understand what part of the vessel you're talking about. So yes, so the point that he's making here is that you can have a puncture of the vein when you're trying to put in like a needle for access, because you've gone too far. And especially with veins, veins are thinner walled as compared to arteries. Arteries have more muscle in their walls because they're under that high pressure from the pumping of the heart. Versus veins, they're thinner walled because remember, there's lower pressure. So they're just trying to get the blood back to the heart. And so the least amount of friction or resistance that you have, the better that that blood can be pushed towards the heart. Okay. And just as a reminder, if there's anything confusing or you need me to repeat anything, by all means, ask me to stop, ask me to repeat. Happy to do that. Okay, so our next correlation that he lists, absence of your pectoral muscles. I believe this is called Pollen Syndrome. And there's no disability, and it'll be absent, like the fold there will be absent. And I think I mentioned that somewhere. Hold on. Let me see if I can find Pollen Syndrome for myself. Oh, hold on, no, this would be in superficial. Just in superficial back. Did I do Pollen Syndrome? I vaguely remember having it. There we go. So it's not common, but it does happen. It's just you have absence of your pec major, usually the sternocostal part. It's uncommon, but when it does occur, there isn't any disability because you do still have pec minor there. Or it'll be like they're not missing, but they're smaller. So that's the hypoplasia here. But yeah. And sometimes you can have an absence of like the rib as well, but that's just like another variation in human form. It's just the absence of your pec major or pec minor or both. And yeah, that's Pollen syndrome. Okay. And then paralysis of your serratus anterior. Okay, I mentioned this yesterday, but I'll go over it again because it's a question that they like to ask a lot on quizzes and tests. So this is wing scapula, and there's a really good picture here. This is from your Moore textbook of wing scapula. So notice here on the left side, you see like there isn't any protrusion of the scapula. It's being held against the posterior chest wall with muscles normally, like this is fine. But this right side, you can very prominently see the outline of the right scapula on this patient. This is wing scapula. So your serratus anterior muscle is innervated by your long thoracic nerve. Recall that long thoracic nerve takes fibers from C5, C6, C7. The mnemonic that we use for this to remember this is C5, C6, C7, wings to heaven for winged scapula. So your serratus anterior, that muscle is helping to hold your scapula to the posterior chest wall. So when you have paralysis of this muscle, obviously you then are not holding the scapula to the posterior body wall. So when you have your patient stand up against a wall and you have them put their hands on the wall and then they push, it'll be very easy and very obvious for you to see the scapula being pushed back because it doesn't have a muscle that's holding it to the posterior body wall anymore because your serratus anterior has been injured. Sometimes in questions, I can recall it being the setup being a knife fight because your long thoracic is on like the lateral side of your body. So it'll be a knife fight. It'll be like a bullet that gets grazed off the side of the body. It could be a car accident where the person like got an injury to the lateral side of the body, something on the side of the chest wall for long thoracic nerve damage, thereby paralysis of your serratus anterior. Okay. Enlargement of axillary lymph nodes. So when you have a lymph node, and lymph node are these clusters um, in your body, all over your body, and lymph fluid goes through them, but also there are cells that live in your lymph nodes, specifically for gobbling up pathogens and mounting an immune defense if you get sick. So when you have enlarged lymph nodes, this is why when you guys start learning about physical exams, the doctor will feel underneath your neck and feel along, or like feel underneath your chin, feel along your neck, trying to feel for those enlarged lymph nodes. If you have an enlarged lymph node, there are many different reasons why you can have it. Most commonly is your body's fighting a cold, or your body is fighting some pathogen that's come in. You can also have enlarged lymph nodes from cancer, but more often than not, it's because you have some sort of sickness. Now, where was it? When you see here the enlarged lymph nodes in the axilla, though, that's when we start thinking about breast cancer. So the cancer would have started, and most commonly, thankfully, breast cancer happens in this upper outer quadrant. So the cancer would have started here and then spread to the lymph nodes here. So feeling in an enlargement of those lymph nodes, that's when the doctor would recommend that the patient goes to get like a mammogram and then possibly a biopsy, depending on what they see on the mammogram, which you can see here. This is a mammogram. This is the, I think it's AP view, or is it lateral view? When it comes to mammograms, you have to do them in 2 different views because you have to get a 3-dimensional picture of what the breast tissue looks like. So when the patient goes in for a mammogram, they will take the breast, and this is not comfortable from what I've heard. I'm not looking forward to this when I get older, but they take the breast and they put it between 2 plates where it gets squeezed in a superior inferior orientation, and then it gets squeezed for a lateral medial orientation so that you can get a full 360-degree viewing of the breast tissue, and you're looking for like any calcifications. And then you can see here, they've actually pointed out where you have the enlarged lymph nodes that are there. Oh, there's stuff in the chat. All right, pausing for just a second. Oh, can you hear me now? How am I now?
Yes, we can hear you.
Okay, cool,
We can
great,
hear
awesome. So what was the last thing that you heard before it started breaking up?
Normally, I think we hear most of what you say. It just kind of happens at random moments, so we'll miss like 2 words or a sentence or something like that.
Okay. If there's ever anything that like you miss and you need me to repeat, just let me know and I'll repeat it. Okay. And I think I think that happens when there's a very brief thing where it'll pop up that says my internet is unstable. So if it does that again, I'll just like repeat what I was just saying, and hopefully that will help. Okay, so in this picture, you can see the enlarged lymph nodes here in the superior aspect of the breast tissue, which once again, especially when it comes to older patients, you're worried about breast cancer. You can have an infection that is then spreading through the lymph fluid into the lymph nodes. And obviously he talks about here how the infection in the pectoral region, the breast can produce enlarged axillary lymph nodes. And just remembering that pathway of lymph fluid drainage is going to help you, because they have the option of asking you questions about lymph fluid drainage and you have to identify which node would come next, or which node could have gotten the previous drainage. Having said that, and because I mentioned it, and it is another question that they can ask you, it is very advantageous that the majority of breast cancers are in the upper outer quadrant because we can feel these lymph nodes and we can feel that they're enlarged and then be alerted, oh, this patient needs to have further testing to see if there's anything wrong. Versus there are lymph nodes that are your parasternal lymph nodes here. So breast cancer less likely arises from these inner quadrants, but when it does, it can be more dangerous because it can spread from one breast to the other, or it can spread from the breast tissue throughout the body without you with it taking longer for you to detect it, because it's harder to feel that these lymph nodes would be enlarged because obviously they're right by bone. So it's just like it's harder to like deal with. Let me see. I know I have it in one of my other review slides. Is it this one? Yes, here we go. So when it comes to breast cancer, and once again, this is another picture from more, most of breast cancer is in the upper outer quadrant. So thankfully, those are the ones that we're able to detect with the spread through the axillary lymph nodes. But if you have breast cancer in these other areas, obviously the spread of the cancer is going to be different and it's going to be harder to detect. So that's why you have routine mammograms in patients 50 and above, and in patients who have previous history of families with breast cancer, they'll actually sometimes get mammograms earlier than that, depending on how old their family member was when they first had breast cancer. Okay.
I know you said earlier that they may ask us a question about the pathway that the lymph nodes drain. What's an example of how they would ask that?
So something about, I'm trying to think of how they would worded it, because I remember it's come up like once or twice, and I'm sure it is in a Grey's Anatomy question. Let me see if I have it. I have one here. Nope, not that. Nope. So, okay, I do not have a question here on that
If you can't
specifically, but
find one, that's fine. I can always wait till afterwards. I just didn't know if you had one off the top of your head.
I don't. But it could be something along the lines of like, which one would you biopsy? Like, which lymph node would you biopsy? Or what is the next set of lymph nodes where the cancer could spread? Or they tell you one group of lymph nodes and they ask, where could the cancer have come from? Or where would it be impossible for the cancer to come from? So, for example, like um, if you have cancer in the apical nodes, it could have come from central, but it's not going to come from supraclavicular because the lymph fluid only drains in one direction. Or if you had cancer in the central nodes, it could come from your subscapular or your pectoral or your humeral, but it's not going to come from apical because again, the lymph fluid travels in one direction and the cancer cells will be traveling with the lymph fluid. So that's one way that they could do it.
Okay, perfect. Thank you.
Sure. Animation. Let's see. Dissection of axillary lymph nodes, excision, and pathologic analysis of axillary lymph nodes is used to determine the appropriate treatment of cancer. Okay, so this is a thing that comes up with cancer where if you suspect it in your patient and you're worried about it, or if a patient has some sort of mass as well as an enlarged lymph node, and this is going way more into surgery, so I'm going to try and like pare it down. But they will dissect out, like the surgeon will dissect out lymph nodes to try and stage the cancer. So staging has to do with how far has it progressed in your body versus like how far has it progressed location wise in your body. So that's staging versus grading is what does the cancer look like underneath the microscope. And I'm just going to say this to you, and you won't have to know this until you're in your surgery rotation, like third year. But staging is more important when it comes to cancer diagnosis than grading. Like grading can look scary underneath the microscope, but if the cancer is only in one spot and hasn't moved, the person has a very good prognosis. Versus staging, how far the cancer has spread throughout the body, that's way more important, because no matter what it looks like underneath a microscope, if the cancer has gone from the breast tissue to the lymph nodes and to like multiple different lymph nodes along the chain and then shown up, say, like in a different area of the body, that is a way worse prognosis that's much harder to treat. So we dissect out the lymph nodes to see, okay, we have taken this mass from the breast tissue and we've taken out what's called the sentinel lymph node. So that's the lymph node that's closest to where we found that tumor, that mass of, we don't know if it's benign or if it's malignant. So we take out the lymph node that's closest to it to analyze and look and see, okay, is there any of this tissue in the lymph node? If there isn't any tissue in the lymph node, we can be reassured that this abnormal tissue that we've taken out, we've gotten it, it hasn't spread. If there is tissue in that lymph node, that's when we worry, okay, is it just in this lymph node or has it spread to even more parts of the body? How are we going to then tailor this person's treatment about like when it comes to this cancer on that? So that's why we dissect out the axillary lymph nodes when figuring out like the treatment for a cancer, because if the cancer hasn't spread to the lymph node, then we can just target the breast. If the cancer has spread to the lymph node, then we have to start thinking about whole body treatment because we don't know how far the cells have spread. So it is very important that you dissect out the lymph node, like the axillary lymph node, when you suspect breast cancer in a patient. Okay, variations of the brachial plexus. So we say that the roots of the brachial plexus are C5 to T1. And in general, this is correct in most patients. However, and I will say this a lot, that bodies are weird. So bodies are weird in the fact that, yes, in general, people have roots C5 to T1, but some people have their brachial plexus roots starting at C4. Some people have their brachial plexus roots ending at T2. So in some patients, their actual brachial plexus roots will be C4 to C8 or C6 to C2. So the most common is C5 to T1. Make sure you memorize that, but just know in the back of your head, there can be variation where some patients start a little bit further up or some patients end a little bit further down. Like everybody has variation. The most variable thing when it comes to patients is their blood vessels. So when you learn the map of blood vessels in a human body, just realize that this is just the most common and the ones that like we learn, but there's going to be variation person to person. There's going to come a time where when we get to head and neck, because I think you guys get a little bit of head and neck, excuse me, there's one blood vessel called the thyroid ema, which it's in 10% of the patient population. So like 1 in 10 people have it, which obviously, 10%, you think, why do we learn this? Well, we learn it because it's an artery that's under high pressure that's in the middle of the neck. So when you try and do a rescue airway for these patients, you could mistakenly hit a very high pressure artery and they could bleed out. And because it's in 10% of the population, it's not insignificant. So this is another one of those where the brachial plexus variation, I don't know the percentage of the population that has it, but we learn it just in case our patient is that variation that we come across. So variations in your roots of your brachial plexus. Okay, so the big thing though, when it comes to brachial plexus is injuries. When you injure parts of your brachial plexus, when you injure those nerves, it's going to show up in different ways. So remember that our brachial plexus has 5 roots. And when you injure roots, that's going to then have effects on multiple different nerves downstream of that. So anything upstream of the nerve injury will be fine, but anything downstream of the nerve injury will be affected. So it's very important where along your brachial plexus you have an injury. So the most severe ones are going to be the injuries at the roots, because obviously if you injure the roots, you're then like, that's upstream of everything. So all of the nerves that have some fibers from those roots are going to be affected. So let's see. Does he actually? No. Okay. So this is when I'm going to go into my brachial plexus review PowerPoint because I have stuff on the injuries. Is it in this one? Yes. Okay. So we'll go into that later because you guys haven't gotten, I don't think you've gotten into upper limb muscles as much yet. But let's talk about some brachial plexus injuries. So when you have a tear of the upper trunk of the brachial plexus, so that's C5 and C6, you end up with what's called Herb Duchenne palsy. Most commonly, people will say you end up with a waiter's tip. So the people that have these injuries, it's where you have this hyperextension of the head and neck to the shoulder. So you see this really extreme angle happening in this person who possibly fell from a height or got launched from a car or a motorcycle. Those have come up in questions. Another one that they like to do is like gymnastics. Gymnastics will give you any injury. Gymnastics, motorcycles, those are common. And then as well during birth, when you have hyperextension of the neck in the baby, when you're trying to get the baby out from a difficult birth, that can cause this upper trunk injury, the Herb Duchenne palsy. So remember how I spoke about that you're going to want to know the nerve roots for multiple different like terminal branches and nerves themselves. Well, this is one of the examples of why you want to learn them, because if we're injuring C5 and C6, we know that lesions to these roots are going to directly affect our axillary, our musculocutaneous, and our suprascapular nerves because they all derive fibers from C5 and C6. For people who end up with this type of injury, you'll have a loss of abduction, because remember, you get that from deltoid and supraspinatus, and deltoid is axillary nerve and supraspinatus is from suprascapula. You have a loss of lateral rotation because you've lost infraspinatus, which once again comes from your suprascapular nerve. So your arm ends up being medially rotated because you can't laterally rotate it out. There's no longer that lateral passive rotation. With muscles, when we're at anatomical position, when we're just standing there and relaxed, we have passive lateral and passive medial rotation of muscles, such that if you lose passive lateral, you end up with medial rotation. If you lose passive medial, you'll end up with lateral rotation. Our muscles are in balance with each other. They're working like against each other to stay at that medium. So for this particular patient, they don't have that passive lateral rotation anymore. So now passive for them is medially rotated. You'll end up with loss of flexion and supination, specifically because your musculocutaneous nerve innervates your biceps brachii muscle, and biceps brachii, its main action is supination and then flexion. So because you've lost most of supination and flexion, the arm is extended, which is the opposite of flexed, and pronated, which is the opposite of supinated. And then finally, you're going to lose loss of sensation on the lateral aspect of the upper limb. So remember, axillary nerve has cutaneous innervation in the area over the deltoid, and musculocutaneous nerve is going to help with that as well. So for people with this upper trunk injury, they are adducted, so the arm is towards the body. They are medially rotated, which you can see is turned in. They are extended, so you see how straight that is, and pronated. And then they've lost like sensation up here. So this look right here, this is called waiter's tip. And that's, well, it's the the shorthand for it is waiter's tip, because an old timey thing would be like when you would go to tip the waiter, they would put their arm like that, waiting for the money. So it wasn't like obvious, this is the thing, but it's a way that we remember upper trunk injury, waiter's tip. So upper trunk injury, C5, C6. Contrast that with clumkey, which is a lower trunk injury. So this is C8, T1. So recall that C8, T1, our lower trunk, they're giving fibers to our ulnar nerve and our median nerve. So for this, the patient, this is another one they could do with gymnastics where for the high bar, like the gymnast goes and they try and grab the bar, but they miss it and they unintentionally jerk their arm. So you have hyperextension of like your arm to your chest wall that can like rip out the bottom parts of the roots of your brachial plexus. Also, it could be that during a difficult birth, so like the baby's arm comes out, but not the head. And so you pull too hard on the arm and that can rip the nerve fibers out. And in all things, motorcycle accidents, car accidents, like anything like that can be a setup for any type of brachial plexus injury. So for these folks, because it's C8 and T1, and so since you're losing ulnar nerve and median nerve, you lose the intrinsic muscles of the hand. Ulnar nerve innervates the intrinsic muscles in the hand, and when we get to hand, you'll see that the hand is mostly ulnar nerve innervation with some median and a little bit of radial, but it's mostly ulnar nerve. So your hand gets messed up a lot. So you lose like your lumbricals, your interossei, your thenar, your hypothenar. Like I said, we'll get to that once we get to hand. But just know that you end up with a formation that's called clawhand, and this is what it looks like over here. It's clawhand. And then you lost sensation on the medial aspect of the upper limb. So that is, again, ulnar nerve and I believe median nerve as well. So the biggest thing with clumkey, clawhand. So here's a schematic of your brachial plexus. And just realize that at each of these numbered points, you can have a different injury. And you need to be able to identify what injury it is based on the location on the brachial plexus. So we were just talking about upper trunk, C5, C6. And here's your lower trunk, C8, T1. We already talked about long thoracic for paralysis of your serratus anterior. And then notice here how you can have damage of your medial cord versus damage of your axillary nerve versus damage to your radial nerve, and how all of those are going to be a little bit different. So if you damage the medial cord, you lose both axillary and radial nerve, versus if you just damage axillary nerve versus if you just damage radial nerve. And then also your other three, terminal branches, if you damage them, how you're going to have different weaknesses and loss of sensation depending on what nerve it is based on the muscles and the skin innervation that they provide. So I will send this PowerPoint along to your class president. This is actually a little bit ahead of what you guys are learning because it has more stuff about the muscles of the upper limb, but that's okay. If you want to just review it early, it'll help. But this is your key from when you're testing yourself for what type of injury am I going to end up having depending on where I damage my brachial plexus. So we already talked about our Herb's Duchenne palsy, our clumkey, but also wrist drop when you damage your radial nerve or your posterior cord, specifically. How you can end up with wing scapula, your deltoid paralysis, all those. And notice how wrist drop is listed here twice. Well, note that if you damage the medial cord, you lose your radial nerve. If you damage the radial nerve, you lose your radial nerve. Radial nerve damage and wrist drop are just synonymous because the radial nerve is innervating the extensors, the posterior extensors. So when you lose your radial nerve, you lose the muscles that extend your hand. And so when you can't extend your hand, it's called wrist drop. Okay. So another thing that's important, and I'm just going to bring this up now because I think it's a good time to talk about, injuries to nerves in relation to where you break your humerus. So we've already talked about the 5 different terminal branches of our brachial plexus. Well, there are 4 specific areas that they like to test you on, and how, like, what nerve is going to be damaged if your humerus, what nerve could be damaged if your humerus breaks in these locations. And in 3 out of 4 of them, there's an accompanying artery that you need to learn that can also be damaged with that nerve damage. So we'll start proximally and go distally. So proximally, if you fracture the surgical neck of your humerus, you can damage your axillary nerve along with your posterior circumflex artery. They're actually running together in that area. So fracture of the surgical neck of the humerus can cause damage to your axillary nerve and your posterior circumflex artery. Recall that your axillary nerve innervates teres minor and your deltoid muscle. So obviously with these patients, if they have this fracture, they're not going to be able to abduct their arm from 15 to 90 degrees. If you have a mid-shaft fracture of your radius, you can damage your radial nerve along with your deep brachial artery, which is also known as your profunda brachii. I'll warn you right now, this is another one of those things that has like 2 names. So you can say either deep brachial artery or profunda brachii. And specifically, there's an impression on the posterior aspect of your humerus called the radial groove. That's where your radial nerve is running. So when you have fracture to the midshaft of your humerus, you can damage your radial nerve along with your deep brachial artery, also known as your profunda brachii. This area of your humerus here is your supracondylar area. If you have a supracondylar fracture.
I'm sorry, I couldn't really hear that.
Oh, sure. What was the last thing that you heard?
The last thing I heard was a radial nerve. I don't know about anyone else. It might just be me. I don't know.
So did you hear about the
Yeah.
fracture? Did you hear about the fracture of like your midshaft of the humerus?
No, that was all breaking up for me.
Okay. So when you fracture the midshaft of your humerus, you can possibly damage your radial nerve and your profunda brachii because they're both running here. So you can see how this is in shadow. It's trying to show you that the nerve is going behind the bone. On the posterior aspect of the bone, there's an area called the radial groove. That's where the radial nerve runs. When you think about the radial nerve, think posterior aspect of the arm, because the radial nerve innervates all of those muscles in the posterior aspect of the arm and does cutaneous innervation in the posterior aspect of the arm. So a midshaft break in your humerus can cause damage to the radial nerve along with the profunda brachii because they're running together in this area. For a supracondylar fracture, so this area in the distal humerus is your supracondylar area. So supra means above, condylar, these are condyles here, here, and here. So supracondylar literally just means above the condyles. So the supracondylar area, if you have a fracture here, you can damage your median nerve along with your brachial artery because again, they're both running in this area. This area specifically, not the bone itself, but when you're looking at the upper limb, this area is called the cubital fossa. And later you'll learn that there's 4 important structures in your cubital fossa. Well, 2 of them are your median nerve and your brachial artery. So when you break this area of your humerus, you could possibly damage both of them. And then finally, your medial epicondyle. So notice how you have a medial epicondyle and you have a lateral epicondyle. I don't really hear much about breaks on the lateral epicondyle, but the medial epicondyle, when you fracture that, you can damage your ulnar nerve. Notice how this is in shadow right here. Your ulnar nerve actually passes behind your medial epicondyle so that when you bend your elbow, this is a whole funny bone thing. So when you like knock your elbow and you feel that shock going down your arm, that's you mistakenly, like, that's you hitting your ulnar nerve and you feeling like that shock of the pain through your ulnar nerve as it travels on the medial aspect of your forearm. So when you fracture this medial epicondyle, you can damage your ulnar nerve, which is running posterior to this medial epicondyle. Okay. And like I said, I can send along this PowerPoint. You guys can do like the review later, but I go over, like, there's a whole bunch of stuff here on the muscles, which I don't think we've gone over yet, as well as testing yourselves on the different damage areas and the damage areas when it comes to breaks in the humerus. Oh, and it is 11:48. Okay. So I think those were all of the clinical correlations for Dr. Lobo's, for Dr. Lobo's PowerPoint. And since we only have 10 minutes left, what I'm going to do is I'm going to stop recording and then I will stick around and answer questions for folks. So stop share.